Some of you I recognize by face or name, others I don't, but everyone welcome. This talk that I'm going to give, I want to be interactive. So I'm going to spend maybe the first bit of it giving some background and hitting on some high-level points, big picture things. And then I really am curious to see what questions you all might have so we can kind of dig deeper about different questions about medications or therapies or whatever. So we're going to be talking today about spasticity. And this talk, we're going to be talking, this is geared towards, I see some medical students and others online, but this is geared towards people with spinal cord injuries. So people that would be patients or consumers. So that's kind of the level I'm going to be speaking at. If people need me to go more into detail or less into detail, you just let me know. I think I'm going to rely on Ariani to man the chat. So if you're going to, please try to chat everyone, because I'm not going to be following the chat myself. So like I see someone messaged me, but try and message, you can either message Mar Cortez, which is Ariani in disguise, directly, and she'll see it and she can pass that message along to me if you don't want others to see it. Or if you're messaging me directly, I may not see that until the end, and I'll try and address it then. So before we kind of start in earnest, I think I want to define a few terms so that we're going to be using and talking about. First is spinal cord injury. The word injury, sometimes people feel means there must be something traumatic, but that's not always the case. So injury can be traumatic, or it could be from a tumor, it could be from a stroke. And so anything that causes any amount of damage or changes the way the spinal cord works, we're calling spinal cord injury. And then what we're going to be focusing on is something called spasticity. So we're going to define that. But before we do, it's important to know that there are different kinds of spinal cord injury. So some people that have a spinal cord injury might get spasticity and some might not. That might be a question people have. Why do I have it? And why does, my friend Bob not have it? So in order to develop spasticity, you have to have an injury or some kind of damage to some part of the brain or the spinal cord itself. And the spinal cord basically is like a tail that comes off the brain. And so if your brain is the computer or the motherboard, it controls everything in your body. And from that comes out millions of wires. And those wires are wrapped like an electrical tape. And that's your spinal cord. That goes all the way down to your upper low back. And those wires wrapped in electrical tape are what we call the spinal cord. At the bottom of your spinal cord and kind of in places all the way up, there are little wires that come out like spider's legs. And those nerves or wires come out and they attach to your thumb or your elbow or your feet. And so there are some people that have a spinal cord injury that have it in their very low back. And that part of your anatomy is called the cauda equina or horse's tail. It's a place where there's no more electrical tape and there's just loose wires floating around, loose nerves. So if you get an injury there in those nerves, you won't have spasticity. So everything we kind of talk about won't apply to people with an injury there. It's kind of in the upper low back or up in the neck, in the mid back, things like that. So when we talk about spasticity, what I'm really talking about is reflexes that are out of control. So I'll try and give some examples because that I think helps me understand best. So let's say, if you could think back to a time, if you have an injury before that time, when maybe you would go to the doctor's office and they would take a reflex hammer and they'd tap your knee and your leg would jump, right? And so we take for granted, we say, one of these guys, we take for granted, we say, that's automatic. Our brain doesn't have to think about that. Taps the knee, leg jumps, doctor's checking who knows what. Okay. But there's always brain control over that. And so your brain can always tell those reflexes if it's a bad time. So another way to, let me give you a different example. This one I stolen from Dr. Bryce, which many of you know. Let's say you're walking down the street and you go to step on a nail. Your foot goes to step on that nail, and you could imagine that as soon as the foot feels the nail, it would pull back so that you don't get hurt. And that's a reflex that happens automatically. You don't have to think about it. But let's take that same person that's walking down the street and they go to step on that same nail, but this time they're carrying something precious. Whatever is precious to you could be, quadruplets, or it could be, 10 Fabergé eggs, whatever you want. You could imagine that when your foot feels the nail, it wouldn't necessarily jump back. Your brain might say, you know what, if your leg jumps back, you could lose balance, you could drop one of these babies, or you could fall. So we're going to walk through that nail, even though it's going to hurt us. And so that brain control that can allow the reflexes to not happen is what can be interfered with or damaged or different after a spinal cord injury. And so depending on the injury that somebody has, it could be everything below the injury might be spastic, or it could just be one side or the other, or just one part of your leg or just one part of your arm. And it all depends how much of the spinal cord has been damaged and what particular parts of it that signal from the brain that says no, not now doesn't get to. So hopefully that helps. I'll explain it in one other way that in case that wasn't helpful. So when I tap your knee in the office to get a reflex, all I need is a muscle and a nerve. I don't need the spinal cord to get a reflex. Well, I need a little part of the spinal cord to get a reflex, but I don't need like the whole thing. So as long as the nerve going from the muscle up and then the other one coming back down, as long as those are intact, we'll get a reflex. So the only reason you wouldn't get a reflex is if that was not intact, which is what happens in the cauda equina we were talking about at the very beginning, or if your brain says no. But because of the injury, anything above the spine, there's no connection with the brain, which is the same reason you can't move the muscles either at all or the same way you did before is the same reason that the reflexes can go crazy. So I see a hand raised. I don't know. Maybe we can, because I can't, Ariani's the one muting and unmuting people, William, but maybe if you want to either write a question in the chat or we can do it at the end. I'm just going to go over a couple more things, so there'll be plenty of time for questions. I plan to talk about half an hour, which would leave us about half an hour for questions. So hopefully that makes sense. So I don't know, if it doesn't make sense, please put something in the chat now, and then we'll have Ariani unmute, because that's kind of an important part to understand before we move forward. Okay, so that's spasticity. And so the next thing, so if we that's what I'm going to be talking about. The next thing to know about spasticity is it's not good or bad. It just is. So just because you have spasms doesn't mean you're going to come to the office and see me and I'm going to say, you need to do this or you need to do that. The reason for treating spasticity has to do with whether it's interfering with your life. If you are someone that would otherwise be able to try and walk, but the spasms don't let you, if the spasms are causing you pain, if the spasms are making it difficult for you to get dressed, difficult for you to transfer, anything like that, that's when we want to treat the spasms. There are some good things that the spasms can do. I have patients that use their spasms because their legs will go straight. They can kind of trigger that to help stand and transfer. Or I have patients that want to keep a certain amount of spasms because it keeps their legs from looking, as they put it, too skinny. So there's no good or bad about the spasm per se. The question is it interfering with your life? And sometimes that might be something that's obvious to you. You come to the doctor, you say, these spasms are not letting me sleep, or whatever it is, and we address it. And other times it may not be so obvious. It may be that there's a skin issue you didn't notice that we find at the office that for some reason is associated with your spasm or whatever else. The other thing I'll mention is some patients use their spasms to let them know something's wrong. So they say, oh, you know, I know when I get spasms, that's when I have a UTI, or that's when I have an ingrown toenail. And so they kind of, I have had patients that say they want to keep that because that lets them know to look for something or something's wrong. And so again, there's no right or wrong here. So I just want to make those couple things clear before we get into different treatments. So in terms of treatments that are available for spasticity, there are different ones or kinds. Usually, if you were to go to an office, like say you come to my office as a rehab doctor that specializes in spinal cord injury, you say, these spasms are causing me a problem. The first thing I'm going to ask is, are you going to therapy and are you stretching at home? So stretching and therapy can help with spasms. And they can actually, you know, after a good therapy or stretching session, your spasms can be better for, you know, X amount of time. The question is X amount of time enough for you? For some people, that's 10 minutes. For some people, that's a few hours. And for some people, it's half a day or a whole day. So depending on where you fall in that spectrum, the stretching may or may not be enough from a practical perspective. You know, you probably can't stretch 10 times a day. Then that's all you're doing all day, every day. So, but that's usually step one. And that's usually good to continue doing no matter what. Whether we switch to a different treatment or not, you should always be stretching. And on and off, you might need physical therapy or occupational therapy, depending on, you know, where your spasms are. For the next kind of phase in treatment would be, if we're going kind of from most safe kind of forward to most aggressive, the next is usually some form of pill. So there are different pills. Many of you have heard of something like baclofen. Baclofen is a medication for spasms. And there are some others. There's tizanidine, that's also known as Xanaflex. There's dantrolene, and there are a few others. Baclofen is by far the most common because it tends to have the least serious side effects. So baclofen is usually given 2 to 4 times a day. The reason that we sometimes change how often you get it is because different people's bodies process the medicine at different speeds. So, you know, baclofen usually will last in your system anywhere between 6 to 8 hours. So most people need it 3 to 4 times a day. But different people can tolerate it at different amounts. It can be, usually the starting dose is something like 5 or 10 milligrams, depending on how big you are. And we can get up to we could get up to like 160 milligrams total per day. So that'd be like 40 milligrams 3 times a day or something like that. For baclofen, the biggest complaint that we hear sometimes is that it can make people drowsy. There are some other side effects that can happen from the baclofen pills, but that's the most common. And so the other thing to consider about something like baclofen is it's a pill. So it's really good for, it's like convenient, you know, you can carry, you might already be taking pills, you take it a couple times a day. You know, if it works for you, there's not much to think about or do except, you know, remember to take your pills. It is a pill, so when you take it, it'll go through, you know, it'll affect your entire body. So it's not necessarily good or bad. It's just something to think about. So, you know, if you have spasm just in one toe, you may not want to take a pill, as opposed to someone that has spasms in both of their legs all the way up and down. You know, they may be somebody that's more likely to want to take a pill because they have a lot of spasm that they're dealing with. So that's a consideration. There are the other pills, tizanidine. It works differently than the baclofen, but in my experience, and the research would back this up, again, it's person dependent, but overall, it doesn't tend to work quite as well as baclofen, and it tends to be more likely to give side effects, especially low blood pressure, which I know for some people with spinal cord injury is already a problem. The last classes of medications are things that I don't tend to use much in my office, and I'll explain why. But you might see some people taking or using. One is benzodiazepines. That's something like Valium or Xanax. They tend to work actually relatively well for spasms, but people build up a tolerance or a resistance. So the problem is not at first when you give a low dose, but over the course of years, a lot of people need more. And the more, it's not a safe medication to be taking in high doses. So that's why I don't use it very, very often. The other one is called dantrolene, which was a very popular medication some years back. And it's the only one of these medicines that acts at the level of the muscle. All the other medicines act on your spinal cord and your brain, and that's why it can make you tired or loopy or whatever side effect you could think of. But the dantrolene acts at the muscle, so you don't get those kinds of side effects of drowsiness, let's say. But it is a high risk to cause liver damage. So again, you don't see it very much, and if you know someone or you have a patient or you have a friend or you are a patient that takes it, usually you will need frequent blood tests to make sure that liver is healthy. So those are kind of the basics. Usually I don't see patients build a tolerance to baclofen in the sense that it's not like they need more over time, but most patients do get used to the drowsiness. So after a week or two, they become used to it and adjust. Same with tizanidine. I don't see people build a tolerance in the same way that you might with Valium. So those are the pills. The next kind of consideration, and I guess before I move on to the next consideration, and kind of in the same realm, I'm speaking generally here, so we can't forget, the spasms could definitely come just from the spinal cord injury, but like we mentioned, if you have an ingrown toenail and your spasms are worse because of it, maybe I'll give you a little extra baclofen for a week or two, but the treatment in that case is to fix the ingrown toenail. So I just want people to keep that in the back of their minds. So it's not the focus of this talk, but the same could be said for, like, say you need a new wheelchair cushion because the old one is deflated or it's causing you weird pressure or something else is wrong with your wheelchair. That's the solution to the spasticity in that case. But right now we're just talking about spasticity directly from the spinal cord injury, nothing else that would be making it worse. So the next step up would be some kind of injection. So there are two main groups of injections for spasms. One is an alcohol injection, which is something like phenol. And I don't mean alcohol like the kind you drink, but it's related to that. So the idea here is that we need the nerves from the muscles for the reflexes to go. So the idea of injecting the alcohol is to burn the nerve. It'll grow back in 6 to 12 months, but to burn the nerve. And without that nerve, the reflexes stop. Now, the pros or maybe the good things about this are it lasts a long time, 6 to 12 months. And you come maybe once or twice a year to get it done. The downside is if you have sensation, it hurts a lot. Imagine getting alcohol poured on an open wound. That's what it'll feel like. And depending on who's doing it, it can be easy or hard to control. So if you have spasms, say just in the left knee, depending on who's injecting you, they might have to inject the nerve that goes to the whole leg, or they may be somebody that can just get the nerve that's going to that part of the left knee that we're worried about. And so it's not as easy to do that with the alcohol injections as it is with something like Botox, which we'll talk about next, or the other botulinum toxins like Xeomin. So phenol or ethanol or different kinds of alcohols are an option. But you don't see those offered a lot, and it's because a lot of doctors don't tend to know how to do them, but they're available. The next kind of injection would be something like botulinum toxin. That's Botox or Xeomin or Dysport. There are like 4 or 5 brand names. And it works different than the phenol. The phenol works by burning the nerve, which stops the spasms or the reflexes. The botulinum toxin works at the level of the muscle. So it puts the muscle in like a resting state. Depending on how much is injected, let's say you're hyperactive way up here. If I put just a little bit in, you can be here. If I put a lot in, you can be down here with no spasm. So it allows you some titration or dose management where the phenol does not. The phenol is like all or nothing. So these injections would be good for people that have spasms, say just in one limb, like just one arm or one leg, or maybe if you do have it on both sides, isolated, meaning like just the ankles or maybe the ankles and a knee or two knees. Once you get to more than 3 joints, a joint being like a shoulder and an elbow or a knee or a hip, we may not have enough medicine that we can give you. There's a certain amount that is safe to give, but usually the insurance will not pay for that much. Usually they'll pay for less than that. So the medicine is insanely expensive. So the limitation often has to do with how much the insurance is going to pay. Above and beyond that, sometimes we can petition the insurance for a little more, but often if somebody comes into the office and they have really bad spasms in their hips, their knees, and their ankles, their feet, their toes, we have to make a choice between one leg or the other, or say, let's just do the hips and the knees, or which part is bothering you the most, and then we kind of work our way through it. So we kind of talked about some of the upside and downside of the botulinum toxins or Botox. It's much easier, I can probably do any muscle. I can do your abdominals, your back. I can do just your pinky. So I can get very pinpoint. But there's a limitation to how much I can do at a time, and it only lasts about 3 months. So you're coming to the office every, 3 to 4 times a year. And so for some people, it makes more sense to come to the office, get an injection, not worry about it for 3 months, and then come back. Other people would rather take a pill during that time, take a pill a few times a day and not have to worry about getting injections. So there's some options so far. There's one main option left for spasticity management, and that's something called a baclofen pump. So a baclofen pump, I don't have one with me, but it's about the size of a hockey puck. And the reason that it exists is because some people that get too high doses of baclofen pill, they get too drowsy, or they get, some other side effect, say constipation, or they start to retain their urine or something else. So for whatever reason, they can't tolerate that much baclofen pill. So the pump comes into play. So the pump is about this big. It goes under the skin, below the belly button. So kind of like if your pants, kind of like where the waist is on your pant line, or where the drawstrings are on your sweatpants, that's about the level it is. It's usually kind of on the right side. It can be put on the left side also. And from the pump, there's a little tube that comes out, and that tube wraps around the side of your body, and it goes into your spine. And it delivers liquid baclofen into the spinal canal. And what this allows is for a person to get doses that are hundreds of times smaller than they take by pill. So if you take 20 milligrams baclofen pills and they're making you too drowsy, you could probably get 0.2 milligrams of baclofen for the entire day through the pump, and it would work a lot better and not give you side effects. So that's the whole idea behind why the pump exists. There are some special things to think about the pump or to know about it. So one is, as you may have guessed, if it's a surgery. The pump has to go under your skin. And so you have to go under anesthesia, you have to get the surgery done. Before we put in the pump, we do a test dose. So you get what's a lumbar puncture or an epidural. if you've heard those kinds of words before. It's an injection in the lowest part of your spine, below where the spinal cord exists, and we inject liquid baclofen into your spine. And then we see how you like it. I've never, assuming that the medicine is injected in the right place, I've never seen the baclofen not work. So most people get the baclofen trial done, their legs, the spasms look a lot better. Then they have a decision to make. Do I want to proceed with the pump or not? Then the decision becomes more about, do I want to have a surgery? And then do I want to make the commitment to the pump? So what do I mean by that? So the pump is, it's like like hockey puck size. It's maybe this thick though. And so inside of it is full of baclofen. But over the course of a few months, that baclofen gets used up and then the pump is empty. So you have to go to the office and a doctor, me or somebody like me, will put a needle in it and fill it back up, like going to the gas station. So you have to, not unlike the Botox or similar, you would come to the office every 3 months, maybe every 6, just depending on your dose. The other thing to think about is there's a battery life in the pump. So usually about every 7 years or so, the battery needs to be changed, which is not as big a surgery as the first one, but there's a procedure involved in that for them to change out the battery. And then the last thing to really think about the pump is you can't let it go empty. So let's say you're taking baclofen pill and you miss one, that's no big deal. But if your baclofen pump runs empty and you don't get it filled, you could really go into severe withdrawal. And people have even died from baclofen withdrawal from the pump. So normally what we do actually is a couple weeks before the pump is even supposed to be anywhere near emptying, we would bring you in the office and fill it up super early. But it is something to think about. If you're someone that has transportation that is hit or miss, or you forget about appointments, the pump may not be the best thing because you don't want to miss one of those appointments. You could become very ill. And so there are other things that can be put in the pump, other medications, but for the spasms, baclofen is what we use. And so those are the highlights. I think that was about 30 minutes. And I did that short on purpose in hopes that we would have questions. So I don't know, Ariane, how you want to do this, if you want to unmute people that raise their hands or if people want to put stuff in the chat. Sarah Middleton put something in the chat. Sarah, I don't know if you direct messaged it to me, so I don't know if you want me to read it to everyone. Shoot another message to me to let me know. Otherwise, we can find a way to talk about that later. So Homer put a question in. So it says, some time ago I read only incomplete injuries could experience any sort of spasticity. Is it true? So that is not true. So both people that have incomplete and people that have complete injuries can have spasms. And what I mean by that, basically, if a doctor says you have a complete or incomplete injury, they're really talking about whether or not you have sensation when they do the rectal exam. That's really the only thing. So when we think about spasticity, it's different than thinking about incomplete or complete. There are only one thing you really need to know. Was there damage to the spinal cord itself? If there was, then that person is at risk for spasticity. And if anything, people with complete injuries, especially in the T level or the C level, will be even more likely to have spasm than people that have incomplete injuries. And then there's another question here. Can you talk about managing the pain without a pump? So Deborah, do you mean the pain associated with spasms? Or do you mean pain from the spinal cord injury? So if you could clarify. And then, so Sarah says, can a syrinx be causing more spasms? The answer is yes. So a syrinx is a cyst that can grow inside of the spinal cord. People that have had an injury to the spinal cord, especially traumatic injury, so car accident, a fall, any kind of penetrating trauma like a stab wound or a gunshot wound, they can develop a cyst inside the spinal cord months or years later. The most common signs of a syrinx are increased pain where the syrinx is, whether it's the neck or the middle or low back, and weakness or change in sensation. So if say the pain is in the neck, maybe that your right arm was nice and strong and now you feel like it's weaker, or your hand used to feel with and now it's numb. And then the last one would be increased spasm. So all those things would be signs of potentially a syrinx. And all those things would be, a syrinx sometimes is treated surgically. So hopefully if a syrinx is treated surgically, those things could be reversed, either all the way or partially. Let's see. So Robin is asking more about cauda equina and what we kind of see in terms of a cauda equina injury. So if you remember, I mentioned at the very bottom of the spinal cord, there are a whole bunch of loose nerves called the cauda equina. And if you damage those, Robin's asking, well, what will that look like? And so an injury to the cauda equina, if it's a full or severe injury, the person will have no movement usually in the legs. Sometimes they will in the hips, but usually not, and on a very, very rare occasion, the knee. But usually they might, some in the hips for hip flexion to lift like your legs off the bed. But usually there won't be any movement in the knees, the ankles, or the buttock. And also there won't be sensation in those areas, and there won't be any spasm. The muscles or the joints in those places will be completely loose. So certainly everyone's different, but if you were reading a textbook, let's say, or an article about cauda equina, that's what it would say. And so it would be a flaccid motor paralysis with no sensation. So William's asking about being put back in the meeting. I think that we're going to try and do most of the questions through the chat per Ariani. So I can read what you're writing, so if you're having trouble putting anything in there, then I'll keep reading. So I'll keep going down. So Anji's asking, can CBD oil help? What about THC? So it's hard to say. We don't have a lot of research in the United States. I will tell you there is a CBD THC combo drug used in Europe for people that have multiple sclerosis and spasticity. They're trying to bring it over to the US, so I don't know how long that would take, if anything. And there's some research that, here or there, but here's what I'll say about CBD or THC. As a doctor and someone that is trying to give you information that I can say this is 100% fact, I can't say that yet with CBD or THC. But as a person, I have a lot of patients that use it and they say it's helpful. As a doctor, I can't tell you to do things that are illegal. But as a person, I can say if you're going to try it, please don't smoke it, especially not in like burning a cigarette. There are definitely research studies that show that long-term or even mid-term use of like marijuana cigarettes, if we're going to call them that, or joints, can cause severe lung damage, just like smoking tobacco. So keep that in mind. It's very important to think about in people that have spinal cord injuries, because a lot of people with spinal cord injuries also have issues with taking deep breaths or with their lungs. So if you're going to try it, they have things called tinctures, which are like drops or gummies or some other way to kind of inhale it without it burning smoke. Deborah's clarifying. She asked about, so she's saying, can you talk about managing pain in the legs due to spasticity or in the lower body? So sometimes this is a chicken or the egg. It's a good question. Sometimes it's chicken or egg. So sometimes spasms can cause the pain. In that case, if you get rid of the spasms, then the pain is better. sometimes the pain causes spasms. So if you remember, we talked about like ingrown toenail can make your spasms worse. Well, sometimes if there's some other pain generator or something else causing the pain in your lower body, that can then trigger spasms. So it's really an issue of finding out which is in charge or which is causing which, and trying to address that source. It can be very difficult if the source is the spinal cord injury itself. You may not be able to have another surgery or do anything to reverse the scar tissue that's in your spine. So in those cases, to manage pain, there may be other things that are done. Some people get spinal cord stimulators or try different medications, and we do our best to manage symptoms as best we can. But it's so dependent on each person. I would encourage you to keep that in mind, that as you work with your doctor, you should have something systematic. Say, okay, if we think the spasms are first, let's work through that. And if we think the pain are causing the spasms, let's kind of work through that. Okay, I see you, William. I don't know. I have to figure out if we can unmute you or not with the settings on the Zoom. So there's some other questions here, and then if there's no other questions, I'll try and work on that for you. So there's another question here. I have a patient who reports that if he hydrates and rests, his tone becomes reduced. Have you found this to be a common report? Well, I'll say it. So basically you're saying if you have a patient that's drinking enough water and getting enough rest, that their spasms are less. Well, I'm glad you brought this up. I hinted that pain or something causing irritation to the body could make your spasms worse. It's true for anything. So if you're dehydrated, if you're not sleeping well, if you're emotionally stressed, if you're angry or sad, or something is, you have like a lot of anxiety, then that can increase your stress level. So taking care of yourself, exercising, eating right, drinking enough water, sleeping well, they're all important things in kind of managing spasticity and tone. So hopefully that helps answer that question. Yes, Jose, technically it's not illegal in New York State anymore, but not all my patients are in New York. He was talking about marijuana. Deb says they're not spasms in a traditional sense, but there's constant burning sensation in my legs. Constant burning sensation in your legs generally is related to pain that's coming from the spinal cord, and a pain that we would call nerve pain or neuropathic pain. So you're right, it's different than a spasm. And so it's treated differently. So there are different things that can be done. Medication-wise, there are sometimes injections that can be done. So for step one is kind of figuring out the pain source. Sometimes, just because somebody has a spinal cord injury doesn't mean something else can't be happening, that you can't have sciatica, that you can't have, carpal tunnel in your wrist or something else. And so that's kind of step one. Depending on what the pain source is, we may be limited or not limited in what we can offer for that pain. Okay. I don't see any other questions in the chat. I'm going to see if I can unmute you, William, or not. Okay. I don't have the power to do that. So it's not letting me. It's not letting me unmute you, unfortunately. Any other questions or anything people would want to know more about? I went through everything kind of quickly just to see, so we'd have plenty of time for questions. Okay, here's one from Vincent. How does your management change for patients whose insurance don't support treatment of spasticity, especially since you mentioned the extensive cost of Botox? That's a good question. So insurance companies can be a pain in the butt, depending on what your situation is. So my management doesn't tend to change, knock on wood. I haven't had an issue eventually getting things approved. Sometimes it just goes slower. So I might say to the insurance company, I need Botox for Vincent, and the insurance company might, take a few weeks, and then they respond and say, well, we don't do Botox, but we'll do Xeomin, or we don't do Botox unless Vincent tries baclofen pill first, and that pill doesn't work. So sometimes they'll make you jump through hoops, and that can be really frustrating because it delays the care. But apart from that, really, I've not, luckily, been hindered or been prevented from kind of progressing in the way that we talked about, which is usually therapy, and then a decision that, where the decision really starts is, do you want to start with a pill, or do you want to kind of skip over the pill? Most people would start with a pill, even because I can't inject you that same day. So even if you came to the office, you said, I want to do Botox, we might say, well, here, if you haven't tried it, let me give you a couple week prescription of baclofen or whatever, because it's going to take a few weeks to get the Botox approved anyway. And at least then we're not wasting time in between. That would be the case for like somebody that may be new. But if you've been dealing with this, then odds are you've tried many different medications already. So then approving something like an injection or a baclofen trial would be less of an issue with the insurance company. Okay, so then Claire asks, can changes in the weather have an effect on pain or spasticity? Yes, they can. A lot of people get worse spasms and pain in the winter when it's cold. And some people actually get that in the summer when it's warm or hot. So it depends on the person. Generally, I see if someone needs more medicine or increased dose of injection or on the pump, it's in the winter. William asks, does spasticity cause weakness, or is it perceived weakness and spasticity? And can weakness suddenly increase over a 3-month period? So spasticity is not weakness. So can spasticity prevent you from moving? Sure. Let me see if I can give you an example. So I don't know how many of you have siblings, but you say you have an older brother or sister or sibling, and you're an independent person at this time. You're running around playing with your Legos or whatever, and you might be able to imagine a time that they might pin you down, maybe to tickle you or mess with you in some other way. So them pinning you down is the spasticity. So you can't move, they're pinning you down, but it doesn't mean that you're weak. If the spasticity were removed like it was right before they pinned you down, you were moving fine. So spasticity might make you feel weak because you can't move, but it doesn't mean that the muscles are weak. The only way to know how much strength you have in those muscles is to remove the spasticity, if the spasticity is strong enough to keep you from moving. So some people can move their arms or legs even with spasms, and some people can't. And if the spasms are holding someone back, it's possible, when your brother or sister or sibling let go of you, that there wouldn't be any strength there. It's possible that there would be full strength or somewhere in between. And odds are the longer you've had spasms, somebody's holding you down for 10 years, when they let go, those muscles are going to be super out of shape, and they're going to be weaker than they might have been at the beginning. So sometimes it's also a process of, as the spasms are released, to slowly build up that strength. So hopefully that helps answer that question. And then, can weakness suddenly increase over a period of 3 months? It can. It shouldn't, especially if it's something pretty dramatic. Then it would be good to be seen by a doctor. Maybe you need an image of your spinal cord, or maybe, the one I have seen though a lot in COVID, people aren't working out. And so most of my patients are complaining of increased weakness since this time last year. So if it's unexplained, let's say you were working out every day, 3 hours a day, and now you're not at all, and you feel weaker, then there's a reason for that. But if you can't figure out, or it doesn't make sense why you've gotten weaker, then you need to be seen. Ken says, I only have spasms at night when I go to bed. Can I reduce the amount of baclofen, and if so, how would that help me throughout the day? So I'll speak generally, Ken. Not seeing you in the office or officially, I can't give you an official like dosing change advice. But if you only have spasms at night, or if someone only has spasms at night, they probably only need baclofen at night. It's possible that the other possibility is that if you're taking baclofen all day, the baclofen dose during the day is enough that the spasms are controlled, but at night it's not enough. So it usually has something to do. So usually people that tell me that, they say they have spasms at night, it's more about when they lay flat. So also maybe when they take a nap on the weekend, or if they're flat in bed, that's when they get the spasms. So it's good to look at your mattress and see if you need extra cushioning somewhere, or think about whether you change position in a certain way, if that affects your spasms. There's only so much you can do with the bed and sleep. So if you needed it, that could also be turned up. But the spasms at night, especially if they're getting worse over time, is something you should talk to your doctor about, just so they're aware, because sometimes there are different things that can cause that, especially if it's just at night and it's getting worse. Here's another question. My spasticity improved when I stopped baclofen, but I'm still having issues even though I stretch every day. What would be the next step? So, the question here is still about what you'd want to do. So you have options. The options would be a different kind of pill. We talked about tizanidine and some of the others. There's a couple others that even I didn't mention. And, beyond that, depending on how much spasm that you have, there's the option for injections, right? We talked about the phenol injections or the botulinum toxin injection, something like a Botox, or the pump. So you have a lot of options still, and some of those still include medications. There is, in terms of therapy, we talked about stretching, but standing frames can help reduce spasm. And then also functional electrical stimulation, or FES cycles. So like leg cycles or arm cycles, whatever you have spastic. So where they put the stickers on you and they shock you, that can reduce spasms. If you're able to do that either in therapy or get one for yourself. There's a question, what's a standing frame? So a standing frame is basically for someone that's not able to stand up on their own. You either transfer yourself, or are transferred into a seat, and it cranks up until you're in a standing position. So that's for someone that wouldn't have the strength, or maybe their spasms are too strong to stand up on their own. Has epidural stim helped spasticity? That's a good question, Sarah. I mean, epidural stimulation is generally used for pain. So I can't think of a study, maybe there's one I don't know about, but I can't think of a study off the top of my head with electrical stimulation that's focused just on spasm. So usually when somebody gets epidural stimulation, it's generally for pain, unless you're part of a research study. Like, I guess what I'm saying is, what will insurance cover right now today? They'll cover electrical stimulation in your spine. They can implant something, it's surgical, for pain. If the pain from your back is causing spasms, then that might help your spasms also. But that's the only, there are some research studies that were happening before. I think these have been paused. Maybe they're starting back up now, where people are putting stimulators in the spinal cord to try and stimulate strength and bowel and bladder function. So there is a doctor, I'll put the name in the chat, just if anybody's curious, in Kentucky, Dr. Harkema, who was doing this research a few years ago. And so they have some data on spasticity and stuff, but there's no treatment option right now that would kind of be covered by insurance for electrical stimulation just for spasticity. You'd have to have some kind of pain and then hope that that would help. All right. I mean, there have been a lot of good questions. I have time for maybe one or two more. Oh, here's one. So, why is my bladder control getting worse and not better? Well, it's hard to say. I think, not to share too much about any one person, but so I'll say if Deborah, based on name, is a woman, and depending on how old you are and what your body's been through, bladder control can be worse in women as they age, especially if you've ever had a child or had any issues in your, like say, had fibroids or different things happen. And if you've been catheterizing over time, women have a lot of trouble as they age with incontinence. So that can be a little complicated with spinal cord injury because you can have the incontinence from the spinal cord injury, you've adjusted and adapted to that, and then all of a sudden you hit, whatever age, or something happens and you start to have different kinds of incontinence. And that has a lot to do with the fact that a woman's urethra is very short. So a man will have a penis, and so the urethra is longer, and it takes longer to leak out a hose than it is something short like that. And so that's why a lot of women end up in the long run having some amount of incontinence, even if it's mild. Sorry, I didn't mean to use any. I'm just trying to say aging with spinal cord injury can be tricky. Then Vincent says, what are options if baclofen doesn't work? Has anyone tried injecting botulinum in the spinal cord rather than the joints to manage pain and spasticity? I don't know anyone that's done botulinum toxin straight into the spinal cord. I can look it up, but I don't think that, based on how the Botox works, because it works at the level of the muscle, it doesn't really do anything to the nerves. What it does is kind of turn the muscle activity down. So I don't know, that's probably why nobody's done it, because just based on how the medicine works, the expectation is that it wouldn't do anything in your spine. Hopefully that helps answer your question. And if the baclofen pill doesn't work, then we have the other pills. The baclofen pump, there are issues with the pump, like we talked about. It's a surgery. The pump is a machine, like a phone. Phones break, so things can happen with the pump. But if the surgery is done right and the pump is working, I've never seen it not help with spasms. The question is, was it the right thing to do? And were there any issues with the pump itself? Then there's another question. Is it common to be spastic throughout the body but not have spasms? Yeah, you can have tone, increased tone throughout the body, and like stiffness. You can have that, especially if you have an injury to the neck. You can have like a baseline stiffness or a feeling like you're being held down or you're heavy. Depending on, what you would look like to a doctor in the office, that might be related to spasms or something similar, or sometimes even it could just be a sensation that's coming from the spinal cord that's like a form. It's not really pain, but we call it a form of like nerve pain, or we call it like a dysesthesia, meaning something that doesn't feel right. So that could be it too. But you kind of need to be examined to see how stiff, like if it's actual stiffness that the doctor can also feel, or it's a perception of stiffness that you have, that you're feeling, but the doctor can't feel. And that gives the doctor a hint as to which it might be, how to treat, I mean. Okay. So what I'll say is, if you have any other, this has been really fun. Hopefully it was helpful for some of you. If you have any other questions, please, maybe Ariane, I don't know if they can shoot them to you, or if there are a lot of them that come in, we can do another round of this, in the future. But I really enjoyed it. So thank you everyone so much for your time and being so engaged. If not for the questions, this would have been boring. So thank you.